thank you for the kind words, and let me first correct one thing Professor Tabri said, which I don't think is true. Nobody has seen anything to the end. I mean, he said he has seen it all in. It's not true. We're all struggling. Oh, okay. If I don't use it, those who are online, okay. Okay, so let me first correct. Let me start with correcting what you said. You are saying it all in past. Nobody has seen anything. We're all struggling, and I must tell you that there is nothing you are going through that we're not going through in Nigeria, and I have a feeling that probably the whole of the developing countries. And because the issues are many, that's why it's been very difficult to get some of these programs jump-started. We're still struggling in Nigeria. There's so many. I mean, why Ibadan has experience is for obvious reasons. Ibadan started in 1948, so it's the oldest university. The forefathers in Ibadan, they started when Ibadan was really competitive. When Ibadan was really competitive, the usage in Ibadan at the time was one of the 5 best hospitals in Commonwealth countries. So at that time, the faculties were sitting down in Ibadan, writing grants that were competing with the rest of the world. So they had huge grants. So doing Doctor of Medicine, PhD, with MBBS and clinical, and the ethic responsibility of intervention was relatively easy for them. When we move forward, you're going to see that some of these things we are talking about, they are related to funding. They are related to our survival as a clinician. They are related to the need to balance our responsibility as clinicians and then our responsibility as researchers, and also to balance our financial status. So these are the issues. So there's nothing you are going through that we're not going through, where we're not going through. And as I go, I'm going to be giving examples to show you that even in Nigeria, we're still struggling with it. But let me first congratulate you for the consciousness, because there's a lot to gain if we have a strong academic activity in our various universities. The university will gain, the nation will gain, the students will gain, the patients that we are treating will gain, and we also were going to gain. At the end of the day, the bottom line is money. At the end of the day, let nobody deceive anybody. At the end of the day, the bottom line is, if you're a good researcher, you are good on ground, you have good network, you can go to conferences sponsored, you can have extra income in addition to your salary. The only thing is that to take off is always very tough, and we need a lot of institutional support. The first thing you are broken, the first item is broken, you're getting your accreditation, you are getting this, so that's it. So when this we've been on this thing for some time, trying to fix things about when do I come and things like that. I'm sure it's not different with Nigeria. This is Ghana, so it's the same sort of deal. So if you are holding public office, it's tough. It's tough. If it is tough here in Ghana, you can imagine how tough it will be with Nigeria over 200 million people. So it's been, and also my responsibility now is setting up a new university. In my ever taken any responsibility as tough as what I'm doing now. Because you are just there. I'm going to show you how we were given just a big bush to develop and how far we were. So when your letter also came, experience in Ilan, it couldn't have been experienced in Ilan. And in actual fact, I was discussing with my mentor. I still have my mentor who is still very active on the side. His name is Oyegureji. He's if you Google Oyegureji is still the leading clinical scientist in Africa. He's attracted more than $50 million to the University of Ghana. So we were just talking and he was saying, how will they say the experience of a new university for you should come and relate the experience of a university on how to build an MD or PhD program. And I told him that the genesis really was that I really listened to my inaugural lecture. And the discussion started from there. So whatever I'm coming to discuss here is a combination, is really my experience in Bible and academia in the last maybe 35 years. So I'm going to make some declaration. This is the outline. I'm going to make some declaration, and then we're going to talk about the background. The title of this one is Clinical Sciences for Healthcare Professional. That is what the discourse of the week have. So then we're going to discuss the scope of clinical sciences. Many of us think that clinical science is about you see patient, you are not seeing patient, you are probably not seeing. No, that's not it. And then the challenges, clinical research and national development, and then we will get close to concluding points. This is about my disclosure, and this is just what I have to tell you that when my announcement as Pioneer Vice Chancellor was done, I think 18th February 2022, and of course you just go to the minister's office and they will give you a letter. Unfortunately, that's the way we do things in Africa. So the Pioneer Vice Chancellor is the person who is supposed to come and start the master plan of the university. You start the master plan in terms of geophysical and survey of everything. And you also do the academic brief of the university, which is so this is the master plan. This is the master plan of our university. And then you can see us, this is one of the first few weeks. They're just going to tell you that you have about 580 something hectares of land, so to build the university. So you just start doing whatever you have to do. So basically, what I'm doing now is I'm not doing the job of a doctor really. Just being I can relate to an architect, to a structural engineer, a surveyor, geophysical. I can relate to all of that. So this is what we do. I'm just instructing. And in the last 2 years, this is what we have done. We built this. This is our university gate that we just built. This is our library we just built in the last 2 years. And this is our faculty of physics and medical sciences. This is our faculty of physics and sciences. And this is the teaching hospital that we have built. We will soon start this. According to the Nigerian law, the teaching hospitals are under the Federal Ministry of Health, while the universities are under the Ministry of Education. So even if a university builds a teaching hospital, the Federal Ministry of Health will have to take over, and that's how it goes. We are not yet comfortable with the concept of experimenting. Let you, this university, own your teaching hospital, let's see how you run it, and let's see how you compare with people who are doing what we have been doing traditionally. The teaching hospitals under General Hospital, under Ministry of Health and Medical Program. In some countries, I know in many of the countries in the Middle East, the university owns the teaching hospital. The university owns the teaching hospital. There is no position that does not have its own high and low. So there's no position that does not have its own high and low. There's nothing that we can do rather than doing that. So these are selling units that are just coming. These are multidisciplinary research.
Maybe
so, like I told you, it's a university that was established in 2021. We resumed 2022. The number of students, our near number of students was 531. While this one, I think we had 674. So we have a total number of 1,194 students. The staff strength is still small. You can see 286. And for now, we're running 13 programs. For now, we're running 13 programs. So that's my disclosure. So what I'm going to discuss now is about clinical science itself. First, we must know that clinical science is a field that evaluates and investigates medical treatment principles and methods in a specified design. So that is clinical science. It combines principles of everything: chemistry, biology, experimental science, evidence-based medicine. So that is the concept of clinical sciences. So that tells us that it's multidisciplinary. So, and as much as possible, our clinical sciences faculty should be able to address this multidisciplinary nature of the clinical sciences itself. Unfortunately, there are also many issues about even the way we carry on things. And later we'll get we'll talk about that. So it's not just about disease, it's about health. So if anybody goes to any hospital now and says, I just pick the clinical records, let us know what the waiting time in hospitals are. Let us, before patients are seen in the clinic, in the outpatient, on the ward, what is the number of days to spend on the ward, and can we correlate this with some certain outcomes? That's a clinical science research. But the person has not even seen any patient. It's just doing institutional system review, but it's doing clinical science. So it's about health of the whole society and not disease. The philosophy is strong. The philosophy is that the clinician itself must have the many roles of the clinician itself must be guided by the science of conducting research, science of conducting assessment, science of consulting, science of teaching, science of mentoring, and program evaluation. This is the basis of clinical sciences. So, like I told you, it's usually a huge faculty. The faculties that we have now, usually you cannot have less than this 10. It's going to be very, very big. Before now, until I think sometimes in 2000, the University of Ibadan were operating a faculty of clinical sciences and dentistry. But after 2000, we started a faculty of dentistry. So, and at that time, for some time, the faculty of clinical sciences continued until eventually Faculty of Public Health, Faculty of Public Health, broke data nursing and physiotherapy, they also broke away from clinical science. So these are the issues and these are the ways things are actually evolving. In some Nigerian universities now, they have started Faculty of Allied Health Sciences. So, and all of these used to be part of the omnibus huge Faculty of Clinical Sciences before. The reference point in Nigeria will be University of Ibadan, because that's the first medical school, and that's where that's what everybody copied. And as we evolve, others also evolve. Usually, many of these departments, you have a dean who is an experienced professor who will be the coordinator and administrator of the whole department, and he is going to be guided, he's going to be supported by some of his faculty officers and then the the bosses. The non-academic, those are the non-academic conditions that approve. Of course, in any of these things, exam, record, registry, excellent, state university. At the end of the day, we may say exam is not the best way of testing anybody, but there's no other way. There's no other way that anybody can put forward. In huge universities, if you go to the likes of Harvard, the likes of Stanford, you're going to see clinical sciences, which is almost a university, because they put everything in there. And this is what our aim should be for our clinical sciences. So you're going to see enterprise research leader, which is about vice president of research. I mean, if you have a department that has maybe about 10, 20 people who have grants of about $1-2 million, and you have another 10, 20 people who have $500 million, and then you have some 5, 6, 7 million CDs, and you're going to you can't be talking about faculty of a dean of faculty of clinical science in that circumstance. You're going to have a vice president of research, vice president, executive vice president, and other things, clinical trials administrator. Then the human resource we also have. And then in those huge schools, what they now tend to do is to create schools and colleges and help them with deans and advisors, and then the department will come farther. Also, if you get it right as we go, and I mean, if each of us here, I mean, if you have about 10, 15 people who have completed their doctorate, and each person has maybe about two, three people doing doctorate under them, with intense research, then you're going to have a huge number of clinical research professionals who will be in the various faculties. So what do our present clinical sciences, what do we do? The basic undergraduate education we do is training medical students. Before now, like I said, when the nursing, physiotherapy, dentistry were taught, it would have been many more non-medical students, nursing, physiotherapy, and dental students. The postgraduate work will include masters of science in the various fields. Masters of science in immunology, masters of science in neurology, masters of science in medicine, and things like that. MPhil, PhD, which is great. It's great to have the MPhil, PhD, MD, and then DSc. There are issues about nomenclature, some people call doctorate of science. In the US is what somebody would call doctor of medicine in the UK. It all depends on the nomenclature, but when you look at the curriculum, you're going to see that they all are probably doing saying the same thing, and they probably can compare. In clinical, because we're talking of medically certified people, there are fellowship programs, which is didactic training in transferable skill. I know that in many, I don't know the issues in Ghana, but I know in Nigeria there are a lot of issues about fellowships and PhDs and things like that. But I always say it that whoever thought and come up with the concept of fellowship training for doctors has been wonderful, because it trains, the fellowship training is clear about the hands-on training, and it also is also clear about giving the trainers the understanding of the philosophy of the practice, and that is what matters. The rest is what we have to add, and that is the concept of, okay, let's expose people to research during fellowship training, and then as they do the clinical work, they get involved in research, and then they have publication, and those researches can be put up, and you can now have, we can now have maybe a doctorate or a master's or a PhD, as the case may be. But because the fellowship is silent on that, there are attempts to politically outwit the fellowship. So some people will say, oh, once they don't have doctorate, they don't even have the certificate to teach in the university. That's the kind of thing people want to advance. But we know that that is not true. And for me, the kind of way I respond to them is, in the University of Ibadan today, anybody who falls ill in the university is coming to University College Hospital, which is the faculty of the resource in the Faculty of Clinical Sciences who will treat such people. When University College Hospital and when the University of Ibadan has problem in court, we go out to hire another senior advocate, despite the fact that we have people in Faculty of Law. So, which for me, when in fact the University of Ibadan, when they have cars spoiled, they also go out to look for mechanics. They don't go to their Faculty of Engineering. But in Ibadan today, the resource staff of the Faculty of Clinical Sciences is clearly shoulder higher than whatever anybody can see as doctor. So for you to now say people who have that amount of training, that certificate does not expose them, it does not even qualify them to teach in the university, I find that argument a bit illogical. So, but many of these things we know there's politics in it and things like that. So, if you have a robust clinical science faculty, you have to be doing a lot of training. Training of physician scientists, translational. Now is becoming a huge thing, and biostatistics, and so all of this will come into the picture of the responsibilities of those who are going into the doctorate in this faculty now. Beyond whatever we train as researcher, the most important thing is competence, and that is the emphasis of training in clinical sciences now. So the issue is not just about the number of publications we have in this and that. We also must have competency in how to do those things, and it's a big deal. How to do our various statistical survey, how to do the various things in the lab, the various things, metabolomics, genomics, the hands-on things we need to have. It's the same thing. I mean, it's just like the same thing with our clinical work. Endoscopy, I mean, if you don't know how to do endoscopy, to what extent can you say you are an endoscopist? Even if you have 100, 200 publications on endoscopy, so those are the issues. To what extent can you say you're a surgeon? If you say, oh, I'm a head and neck surgeon, I've not opened the ear before, I've not used the ear to enter into the brain and things like that, and we say we have many publications. So we need to emphasize on competence. So emphasize on competence in research operation, emphasize on competence in research management, and so on and so forth. So the coverage of clinical sciences department is the example of what I've shown here. Behavioral and cognitive function, metabolomics, integrated physiology, productive. All of these are supposed to work together in achieving translational research. At the end of the day, what we want to do as the result of our research activities is an improvement in quality of life of ourselves and an improvement in quality of life of our patients. What we do now is not going to work, and that is everybody's working in silos. Everybody working in silos, and that is a major demerit of our research effort. We're doing a lot of effort, but because somebody says this is the role of immunoglobulin in the development of hepatitis media. This is the role of immunoglobulin in development of pneumonia. This is the role of cytokine in resolution of diseases. This is the role of cytokines in post-operative surgical recovery. The study just ended there. We're now going to go into other pharmacology, biochemistry, physiology. This thing, is there any way we can look at it together and see how we can translate it to something that actually can become what I said earlier, money for all of us? And this is where we all fail. But I think the issues are many. The issues are on all sides. The medically trained, they have this traditional belief of the doctor as the head of the team. But the world is changing, and what the world is saying now is a team approach to everything. So, but that is causing a lot of issues. I know one of the most difficult jobs to do in Nigeria is to be Minister of Health in Nigeria. It's tough. The doctors are going this way, the nurses are going that way, the medical laboratory scientists are going this way, the physiotherapists are going, and nobody is talking about development, and that's why the place is not. That's why we're having issues. And I've always wondered. I mean, if a hot head like me has the ear of the minister, how do we address it? Maybe what we address it is probably the kind of thing they do in developed countries. Just pay people according to their contribution. If you have a lab, and I can assess what is your lab supposed to be giving, contributing to the hospital, From that, I can assess the relative, the proportionate salary that you're going to get from it. If it is like that, if a doctor and a scientist, if they enter that lab, I have no doubt that they're going to cooperate. Because if you don't, you are going to reduce your salary. If you do, you are going to increase your salary. But now that people just sign and people are paid according to certificate and things like that, then anybody can come and become a monster in where we're supposed to be talking about what are the things that are supposed to be coming from this lab as an advancement to the society. So these are the issues that you should consider. So what is clinical science research? You know, I've told you before, many of us have this feeling that clinical science research is about you must see patients, you must do this and this. No, it's not just that. It is just anything that we can put into practice to improve the scientific investigation that will lead to improvement in the health of humanity. That's all. So that's why you hear people talking about longevity and things like that. I mean, these are researches about advancement of human being and improvement in quality of life. But you are not seeing people who are ill. So it's not just about disease. These are the various scopes. You can see each scope: community-based trials, epidemiology, therapeutic intervention, disease mechanism, etiopathogenesis. So somebody will just observe, oh, this is what I noticed. I observed that two patients have air discharge, and one of them, this group improved. This group that improved is because they secreted this kind of cytokines. And then somebody goes back. We're supposed to go back to physiology and what they call life sciences, and then we try those cytokines on rats and see how it comes out. And then from there we can now take it up from pharmacology, drug metabolism, and things like that. But we're not doing this. Indeed, what we're trying to do is to say that there are lines of separation, and any line of separation that we introduce, we do nothing other than to injure our status, and we can see that in the issues that we have. Preventive and health promotion, behavioral research. So it's a huge scope. It's a huge scope in a clinical science research. So it must be holistic. You can see basic research to clinical research, and that is you're talking of translational research, and then even after you have done, you have improved the clinical, you can identify an improvement in clinical outcome. How do we improve the health of the society itself? Again, translation of your clinical research, we do that. So we need to work together. We definitely need to work together. What is the issue? You know, I've told you this before. Funding. Funding is a major problem. Funding is a major problem. The one that applies to us already is the fact that we're in developing countries in Africa, where the leaders have not been able to understand the connect between improved funding of research and improvement in the health of the society and even in the economy of the society. If government improves the funding of research, let's just say that government improves the funding of research in UDS, And if we now have a laboratory where all you do every 2 weeks is you receive samples from all the suburbs. So some people will take them down, logistics, maybe in cars, in motorcycles and things like that. That's the job for those people. If we say in this laboratory every week we use 2,000 test tubes, we use 2,000 steak caps, we use 2,000 wraps of needles and syringes and things like that, and we're multiplying this every week. Is improvement for some people in town selling things, but we have not. In addition to that, is you employ research assistants, and they are paid stipends for what they do. It's not free money. You're not giving them money. You're not giving them free money. It's not as if you like them or you don't like them. It's a function of what they do for you. So you will go to I don't know the next town to Tamale. Go and collect. We have spoken with some deaf people. We have somebody, a research assistant is going to go with you. Who's going to collect the DNA? Who's going to collect the DNA of these deaf people and their family? He's a research assistant. That's his job. You are giving them job, but the leaders have not been able to understand that, or maybe we have not been able to make them see it or convince them that it is like that. So generally, there is little or no funding of research in Africa. Very little. Even beyond, we can talk about it, even beyond the issue of they are stealing, it's not, even the little that is available, nobody is talking about it. Let us fund research. And it's a major problem. Most of the researches happening in developing countries have been funded by grants outside those countries, outside that institution. It's been NIH grant, EDCTV grant, Welcome grant, and so on and so forth. What is our government doing? And until our government is committed to it, they can't even talk about this our own health priority. But what will happen is, American government will say this is our own health priority. What we want to do in the next 10 years with $1 trillion is non-communicable diseases. So, bring proposals, hypertension, diabetes, arthritis, this, that. So this person will come from the background of economy, this person will come from the background of public health, this person will come from the background of science, this person will come from the background of core clinical science, medicine, endocrinology, surgery, orthopedics, and things like that. So this is the money that we all struggle for. So they now say, okay, we want to know what the blacks look like. Okay, so you in Ghana, you be the country leader of genomics of diabetes. So the endocrinologist and the orthopedic surgeon, they struggling with that and things like that. It's okay. But the fact of the matter is, our leaders are not doing enough. We have a force to take. We must be frank with ourselves. I'm sure we're probably not doing enough talking to them. Number two, also, maybe at times, our own posture or our posturing is also not reassuring enough to them. So, because as much as you can say, we can say, oh, politicians are like this. We can also not say the exact opposite as true for academicians. No matter what you say, and that's the truth of the matter. So it becomes difficult to trust us with money. So we must. So what are the sources of funding for researchers generally? Government, very important. Many of these ones that we talk about, it's still government at the end of the day. NIH grant is, before now it used to be 13% of the US budget. And you can never, and they have never had a president who became so drunk and said, oh, this year we're going to make the 13%, 80%, because I want to do this, the kind of thing that we see in our own government. I mean, I was listening to some people talking about the radio, and they say, oh, the funding for basic education in Ghana has not been released to the primary schools for some time. The kind of thing we hear in our own setting. But at the end of the day, it's government. The one that we may say is not government is maybe the ones from Wellcome Trusts and things like that. That's probably GSK and many of the drug companies and some of those scientific companies, scientific research companies. Maybe. But at the end of the day, it's government. At the end of the day, NIH is government. British Research Fellowship is government at the end of the day. You can do crowdfunding. There's a limit to what you can do with crowdfunding. Philanthropic funding. Some maybe the Aliko Dangotes of this world, maybe those ones they can be. I'm sure the equivalent of Aliko Dangote was probably trying to do something. But what they can achieve is not as much. It's not as much. They are corporate partners and the American media. So these are the sources of funding for research. One thing we must know is that the higher the funding, then the deeper the depth of the research. That's the thing. It's just basic. There's nothing anybody can do it. They can say about it. If just the bottle for storing DNA, one of the times I was looking at research, it's about $10 per bottle, and I'm going to use about 1,000 of those bottles. Start. You're talking about $100,000 just for bottles. So how much of a CDs or naira can we contribute to buy the bottle? Let alone people have to travel. People have to travel to get our DNA, to get DNA from deaf people in Nigeria. We have traveled the equivalent of maybe Accra to Tamale, traveled from Ibadan to Katsina and the rest. So how many times can you put people on, even if it's before now, we can even try it, say let's go by road. But now we can't try it. We can't try it because the road is not safe. There's a lot of communal clashes and kidnapping and things like that. So if you fly down things like so, even if you want to go, even if you say you want to go by road, then you have to employ, maybe you have to employ one BSS, employ one police officer, and buy. All of these, they go into the cost of research. So if you don't have a huge funding, you cannot talk, especially huge epidemiology and genomic researches. If you don't have huge funding, you can't even dream of those things. Let's be clear, there's no discovery or innovation without a deliberate effort to fund clinical research. That's what I'm saying. If you don't fund clinical research, we'll just be doing what we do. What we do most times is hospital-based research. The strength is slow. That's why for most of it, if I start asking basic questions now, we don't have answer. We don't have answer, just like we don't have answer in Nigeria. If you ask me what is the prevalence of deafness in Nigeria, I can't answer because we don't have funding to do prevalence study. Prevalence study is not what you do inside. It's not what you do inside the hospital. Out of 10,000 deafs that enter Kolebu, teaching us to do some of it. No. There are deaf people in town who are not, who you don't even know at all. So with our capacity to investigate it has to do with funding. If I ask you what's the prevalence of breast cancer, what is the prevalence of prostate cancer, what is the prevalence of prostatitis, what is the prevalence of, we don't know because we do not have the capacity to research into those things. Basically because we don't have the funding. Again also, because we don't have the funding over time, we also have lost the expertise to do those things. So, and that is why now we need to train all the time. When you get funding, these are the things you want to fund. Like I told you before, the people, your research assistants, the subjects that you have to mobilize the subject. It's done everywhere. I mean, I've gone inside the bus in the United States before and I said they're doing one study on schizophrenia. If you volunteer, it's $1,000 to one person. So everywhere is done. And this goes into the cost of the research itself. So facilities. If you have huge funding, and you have huge research, they can write off some ultrasound machine for you, they can write off some CT scan machine and things like that, They can build a small laboratory for you. Even if you say, okay, you must have a space, then you can put in your researches, laboratory infrastructures, and it will be because they know that after that research, at least that will continue as your training space and improvement in the capacity of the institution. So these are the ways researches benefit individuals and institutions. So infrastructure, equipment, people, distribution, and publishing. Even when it comes into publishing, that's one of the things also now some of those publishers will say, hey, if you are publishing from a work that is funded, you take the money for that from that your grant. It's not the logic is clear. So how do we create and sustain clinical research? It's huge. One, we have to involve all the stakeholders in the design. So like I said earlier, we're not working together well enough. Well, and that's why the researchers the researchers have just become something like, let me research, get publication, and get my promotion, and that's what. But if you have each research, if you have a research that involves neurology, pediatrician, surgeon, statistician, physiology, and it's very difficult for such researchers to be extremely difficult. So we have to get a huge stakeholder, get a big design, and build partnership across within the institution and outside the institution, both the way they say horizontally and vertically. So this is the importance of clinical research. It is the source of evidence-based medicine. The source of evidence-based medicine. Even the ones that we do within the hospital, we know it is the source of evidence-based. So what we do is we look at we do our observation. We do our observation. And somebody just look and say, do I have to, if I have done 25, 30 laryngectomies in the last 3 years, and I have not transfused any of those patients with more than 1 unit of blood, then why should you tell me that laryngectomy, group and cross-match 4 units of blood, group and cross-match 6 units of blood. And these are the things you will see the EN surgeon, the surgeon, and the anesthetist talking about. If I don't have 8 or if I don't see 4 units of blood, 10 units of blood, I'm not going to allow your patient to be in theater. But what we need to sit down. We have hospital data. We've been doing these surgeries in our hospital forever. So let us even go back to 5 years ago when all of us were there when we were doing it. We may not be able to say that we may be saying that okay, the people who were doing it before us, those ones were idols, they were so good at. But between us, let's separate it. So we examine our data and say, okay, in the last 5 years we have done about 35, 40 surgeries. But there was only one patient that had 2 units of blood. All of them have never had more than 1 unit of blood transfused after surgery. So what is the basis for group and cross-match 4 units of blood? But the basis is traditional. This is how we all do it. Oh, group and cross-match 10 units of blood. As if it's water. It's not water. And now that, because even if you say, yes, donate blood, what we're using as blood bank, the electricity that we're using to maintain the blood itself, they are expenses that somebody will have to pay for. Not just that. If we say group and cross-match 4 units of blood, if we don't use the blood, are you going to pay that family? Are you going to refund them the money to pay for group and cross-match? These are all the issues we all need to sit down, and then we can start improving practice. So I've said this one before. African countries do not invest in Ghana. You can see the call for funding during the COVID-19 saga. The published COVID-19 funding opportunities by continent. And Africa is almost nowhere. Europe and America are the ones doing it. They are the ones calling it. But it's not going to be for fun. We eventually now saw what happened when COVID vaccine was manufactured. And then the people who funded it decided that they will keep the number of vaccines for their population. And then that was the time we now started talking about equal opportunity, equal life. And when it was funding, we were not talking about that. We were not talking about that. So, but now, vaccines are being produced. Okay, they said, okay, now we have vaccines to even treat for all the people who are COVID. Then we want to give this certain percentage. Then the ones who don't have from development say, no, you should be fair to all. No, you will be fair to all if all have been fair to their pockets. So those are the issues. If you don't do what we're supposed to do, we'll still get the result sometimes later. And we got that result almost immediately. But Africa is the largest beneficiary from Europe and America. I've said that, I've talked about this. Most of the research is going on here. They are funded from outside this region. They are funded. It's so convenient for them. That's why it's so convenient for them to control many things. If you go and do, some of us we do researches that we send samples abroad. And I always tell you, when you leave and you leave your samples behind, what did you know that was done to those samples? And that is why it's also difficult for us to claim leadership in many of those researches. Because one is not done in our own home. So they have contributed much more to it. So and it's so the same thing HIV research are put in African countries. And you can see that Nigeria, this is Ghana, this is Nigeria. They are the ones who have done for 1,496 to 26,000 populations on HIV. And all of this is just about availability of funding from outside those countries. It's not because Ghanaian and Nigerian government are doing anything different from this. So factors contributing to continued underdevelopment of clinical research enterprise. Yes, this one. First is, you can see the first one we put, the extra time and expense required for clinical research training with its inherent complexity, difficulty, and cost of patient-oriented clinical research. This is one of the reasons why clinical researches have not been going on well among medically qualified in our clinical sciences and hospitals. This one of those. The other one is the declining ability to cross-subsidize clinical research from hospital and faculty clinical practice. I mean, if you want to do researches on breast cancer patients, they're still going to pay for they're going to pay for most of their treatment. So you are already limited. But if it's a function where the hospitals can say, okay, we're going to provide these drugs to use to treat them, then you can ask, randomizing you to this drug, another one, this drug, another one. But so many times, if they are paying, you are under ethical, you have an ethical responsibility to give them the ability to choose the best of drugs. So most times, most of our patients are taking probably the same drug because it's not the hospital that is paying them. It's not the hospital. It's the same thing with many of those other scenarios. Then the debt burden that inclines many physicians in training to forgo clinical research career for more likely rewards of clinical practice. That was the first one. That was the first one I mentioned. When we all were trained, and then we trained clinical practice, we became fellows and yeah. Because researches were not coming regularly as part of the training, those who had it, they went out of their way to have it. They went out of their way. Indeed, when I was wrestling, many of the researches that I could say really killed me, they were not even in surgery. They were not even in surgery. They were in medicine and epidemiology. So, but that gave me the opportunity to see how they were conducting those things, what was supposed to be going into developing grant proposals and things like that. So that was it. So if you become fellow and you now say, come and be doing clinical research, the first thing, the first arithmetic is, if I do 4 amputation, 3 prostate, 1 mastectomy, these are how much I need. On the other hand, I will follow patients who have breast cancer home, I will assess them, reassess them, I will be taking taxi back and forth, I will have assistants I have to pay for. and then the result is not coming immediately. If you do your surgery, you are taking your money immediately. You are taking your money. If you go to any private hospital and you see a patient, you are taking your money. If you do researches, it is a long-term investment. And like I say, school fees will not wait for a long-term investment. Your wife will not wait for a long-term investment when you cannot put food on the table. That's one of the reasons why researches even people who have research potentials among the leagues, they have not been committed. They have not been committed. And it's not as if the hospitals have anything to give. So that is one of the reasons. The other is the uncertain status of the full spectrum of clinical research within the culture of academic health centers, where traditionally basic science and clinical programs have often been valued more highly than clinical research. So these are the issues why. So, but clinical research has many benefits. We all know. Those researches, they will give us new techniques to investigate patients, to make a diagnosis, and we make a more accurate diagnosis. I mean, you can imagine when clinical practice and research is just about plain X-ray and digital X-ray, compared to now that we have ultrasound, we have CT scan, we have MRI scan, and then in some cases, if you have a cancer patient, you have operated or you have done radiation and the person develops another growth or you have a position emission tomography scan to even say this new growth is a new cancer or it is just a fibrosis. So these are the ways clinical research helped in improving practice and the quality of life of people. It provides life-changing treatment. It prevents people from developing disease, and then it improves health and care for generation. And generally, at the end of the day, is ensure better quality of life. Benefit to patients are valuable. Access to state-of-the-art treatment, potential for more effective treatment, health monitoring, access to expired care, and then the chance that we affect society. And to the researcher and society, groundbreaking medical advances were made through clinical research. That's why I always say the fellows, for everybody to say fellowship is nothing. We're doing the research is just that we're straight about it, and people don't want to really appreciate that part of our products. And then at times also, we're doing researches, but we're not publishing them well enough because of pressure of clinical. So those are the issues. Clinical research studies open new doors for researchers. I've said that before. You can travel, you have so many contacts that you have made and things like that. The immediate clinical research studies are successful. It contributes to knowledge and it will good for future research. So this is why they say even a negative finding, so to say, as we say, is a significant factor. Even a negative factor is a significant factor. At least it tells us not invest in that direction and then let's look at that direction. So at times people say because it is also issues in communication. And we didn't find anything. You found something. People say they didn't find. No, we found something. Even if it's a negative finding, the way we now write it is what we now say how publishable that exercise is. It's not that it is not publishable. It's not that the only thing that is publishable is positive finding. No, that's not it. The insight gained from clinical research studies cannot be learned in the laboratory or through animal studies. Absolutely. Clinical research studies show efficacies in human and they can help medical profession. This is just to do a graphical representation of benefit to society and personal benefit. So in conclusion, legal science is a multidisciplinary course and training with variations across institutions. As we grow, as we evolve, we're going to see many of these things are also controlled by our strength, by our area of strength as well. That's how we're going to say, oh, this is how we're going to go, and things like that. The training models are different between schools, but the overall objective is to produce clinical personnel who are scientists and researchers. Clinical research as a component of medical health research intended to produce knowledge value for the study of human disease, preventing and treating illness. Africa will need to develop, especially in the area of investment in research. The overall goal is to improve the health and quality of life. So, thank you for listening. And as much as possible, this is not a lecture or somebody coming. I want us to make it interactive. Let's discuss and things like that. I can share your experience like that. I know our experience is just about the same. We're at the same, we're in the same ladder. We're in the same point of the ladder. There's no, we're at the same point of the ladder. We're all struggling in sub-Saharan Africa to do many things. Because there are so many things that we don't have access to. I think the biggest we probably don't have access to is the instrumentality of the state. I don't know how many of the researchers in Ghana, the Minister of Education, the Minister of Health, contact. Before making a pronouncement, I think these are the issues